Hello, everyone, and welcome to the Ketamine in service for Colorado River Fire Rescue. Jump right in. This is medication protocol 9310. Ketamine, also sometimes called Ketalar. Talking a little bit about ketamine. Ketamine is a non-competitive NMDA antagonist. So the NMDA receptors are receptors on your neurons. There are really three types of inotropic glutamate receptors, and this is one of them. And what they do is when a glutamate plugs into that receptor on a neuron, and a neuron being a nerve cell, right? What that does is it allows positive ions to flow across the cellular membrane. And that's part of how those neurons fire. It gets a little more complicated than that, but without getting too sciencey, basically these receptors plug in with glutamates, allow the neuron to fire. So this antagonist that blocks that receptor makes it difficult for the neurons to fire the way that they are supposed to, which creates that dissociative amnesia effect. So that's how that works. We have two indications, only two, right? One is excited delirium. It's important we point out what excited delirium is specifically, right? It's a hyperadrenergic state and delirium. Hyperadrenergic, that's hot, sweaty, tachycardic, agitated, and delirium, detached from reality. Both of those things have to be present in order for excited delirium to exist. If you can't document those things, you can't give ketamine for excited delirium. And in addition to that, the safety of the patient and our providers has to be in question. It has to be an unsafe situation for you to really be able to justify that. It can't just be a sweaty guy who's a little confused, but generally benign. So that's important. Next, pain refractory to other treatments or where other pain medications are contraindicated. This is an important sentence. So normally we treat pain with fentanyl, morphine, other opioids, or maybe in the instance of spasms or something like that, we would use a benzodiazepine. You have to try something else before you try ketamine. You have to have a documented attempt at a different intervention for pain control before you use ketamine. It's not a first-line drug. And this is important because that doesn't mean you can, draw up your fentanyl, your 50 of fentanyl, give it real fast, and then drop the ketamine right on top of it. You have to give it a minute, see if it works, try it out. And the reason for that is there are a lot of things that can go a little weird with ketamine. It's not a dangerous drug, but it does have some adverse reactions that we try to avoid. And ketamine is not nearly as benign as some of our tried and true drugs. So make sure you're documenting and doing your other treatments beforehand. The other option here, if your pain medications are contraindicated, one, either through a traditional allergy, right? If somebody's allergic to fentanyl, or if they're not hemodynamically stable enough, right? If they're hypotensive and you're concerned about making them more unstable, you could document that and say that I couldn't do my trial of fentanyl because the patient's blood pressure wouldn't support it, but I did need to control the pain. That's just something you would document very clearly in your narrative. Contraindications, pretty simple. Relatively contraindicated in both cases, so not absolute contraindications. For penetrating eye trauma, it's just because it increases intraocular pressure in some cases. And then with cardiovascular disease, just because it can cause tachycardia and increase myocardial oxygen demand. These are things you're going to do every single time, and it's quite a list. You're always going to have BVM available, suction available. You're always going to have cardiac monitoring, pulse oximetry, and capnography initiated. You're always going to set up access, and you're going to check a BG. And then you always set up physical restraint for that emergence phenomenon. So these are just things you need to have ready every single time you give ketamine, no matter the reason. Doses are easy. For excited delirium, you have an intramuscular dose of 5 milligrams per kilogram. If you need more, call a doc. We only have an intramuscular dose because if you can get any type of venous access, it's not excited delirium. For pain, we have an intramuscular intranasal dose of 0.5 milligrams per kilogram, which you can do every 20 for up to 3 doses. Here's your max per kilo. IVIO, it's just a little bit less, 0.3 milligrams per kilo. Same regimen there. Important to note that what we need to see in your narrative is the math, right? We need to see this equation play out. So whichever dose you chose based on the route, plus the kilograms or estimated kilograms of the patient, and then the exact amount of ketamine that you gave the patient. We can't have estimated doses of this medication. You do need to demonstrate in your narrative the amount of medication based on the weight and the formula you used for that. So that's important. Ketamine kicks in real fast, lasts just about 10, 15 minutes. Some things that can happen: laryngospasm, usually pretty easy to take care of with your BVM. That's why we have it available. Emergence reaction is that kind of anxious, freaked out hallucination state that can sometimes happen as ketamine is wearing off. Often that's not near as bad if you give the ketamine slowly. Intramuscularly absorbed slowly, so you don't usually see the problem. And with IV, if you give it slowly over a few minutes, you're much less likely to have a bad reaction. Additionally, if you combine it with benzodiazepines towards the end when it's wearing off, if you start to see any signs of reaction, that can help a lot. Nausea and vomiting, hypersalivation, both things you can see, but fairly rare. You can give antiemetics, and in the case of somebody with a lot of secretions, you could give atropine or another anticholinergic. It is a medical emergency, so you need to make sure you transport to a facility. You can't transport in a patrol car or to a jail or anything like that. They need to go to a facility for medical care. We carry it in 100 milligrams per ml concentration. That's a 5 ml vial. That's worth noting because if you're giving it to a large person for excited delirium, you might be in the 400, 500 milligram range, right? And so that would be a full 5 mLs of fluid. And that means you kind of need to pick a large muscle group or split it into 2 syringes, right? So you're looking at the vastus lateralis or a quadricep instead of a deltoid, or you could do 2 syringes, 2.5 in each deltoid or something like that. Just be aware of how that would look. We have a very specific way we report this. There's a very cool form attached to this protocol that you need to scan and attach with your report in New World, and also email directly to the EMS chief every single time immediately. We don't really see excited delirium in children, so we're not going to be restraining children with this under really any circumstances. And then in addition to that, if it's not actually real excited delirium and you can't document that hyperadrenergic state and the delirium, you can't use ketamine as a chemical restraint. We're not able to just use it on our agitated, regular, combative people. That's a very, very bad idea. Please do not do it. Then we just have some protocols. This goes a little deeper into some of the ketamine stuff for excited delirium. So most of it we've already summarized. Take a look at that. And then we have just a little bit of a trauma care and where that fits into your pain management, right? Same thing we've already summarized. You have flow charts for either one of those. And then this is the pain management quality assurance form for ketamine, right? So you put the incident number, any adverse reactions you saw, check we did all of these things, put your doses, any improvement in pain response here, any vomiting, check, reemergence, check. This is your max 3 doses, right? You can change that to 0.5 if that's the way you gave it. And then this is where you would document any adjunct therapies that you should have done prior to attempting ketamine for pain management. That's the entire ketamine protocol. If there are any questions, you can just get in touch with your friendly local EMS CQI committee member. Thanks for watching.